زي ما كنا بنقول ان احنا يعني بنشكر كل اساتذتنا على الفرصه العظيمه اللي بتتيح لنا في كل الكونفرنسز وكل الميتنجز اللي احنا بنعملها، ان احنا نبدا يبقى لنا فرصه ان احنا نعرض الحالات اللي احنا بنتعلم منها زي ما حضراتكم تفضلتم وقلتم. احنا هنعرض يعني طبعا انا اقول بشكر حضراتكم جميعا على الحضور، وبشكر اساتذتي، وبشكر يعني بصفه خاصه دكتور بيتر طبعا اللي ساعدني كتير في البرزنتيشن النهارده. احنا هنقول توك يعني precise with two home messages واضحين. Our patient was delivered at 36 weeks as a female neonate delivered by cesarean section with birth weight 2.8. There was no antenatal significant history except for at the 32 weeks of gestation. The baby was diagnosed as complete heart block. Fetal echo showed that the atrial rate was 140 to 160 per minute with ventricular rate 55 per minute with no structural abnormalities. Etiology for heart block in neonate involved autoimmune antibodies or structural heart abnormalities causing displacement or destruction of AV node or idiopathic familial congenital heart block. So the mother was referred and was investigated for autoimmune antibodies and was diagnosed as systemic lupus patient. At delivery room, after resuscitation and initial monitoring and confirmation of the diagnosis, umbilical vein catheterization was done, and through the umbilical vein, a temporary pacemaker was placed and kept patient heart rate at 100 to 120 per minute per the pacemaker basing. Then patient was admitted to our NICU at hour 6 of life, was planned to replace the temporary pacemaker with a permanent one when the patient is stable and fit for replacement. After stabilization and treatment of sepsis, patient was planned for cardiac catheterization for permanent pacemaker at the age of 3 weeks. Failed gaining of vascular access aborted our plan to insert a permanent pacemaker. So at this stage we have a question: what about the patient own basing, inner basing for this patient? We stopped the pacemaker. Patient heart rate at this stage was about 70 plus or minus 5, between 65 to 71, 72 at this range. So the plan at this stage was to wait and see. Wait for what? We were watching for the patient's hemodynamic. What about his cardiac function? What about his perfusion, serum lactate, ABG, urine output, tissue perfusion, and so on. At this stage, the patient was hemodynamically stable. Serial echo showed that there was no dilatation of the left ventricle, and the left ventricle was maintaining the cardiac function. The serum lactate was within normal, and urine output, kidney functions, systemic perfusion, systemic blood pressure, all were within normal. So at this stage, patient was the temporary pacemaker was removed, and the patient was discharged as a plan to insert another one surgically at later on in life. So congenital heart disease has certain indication for insertion and in introduction of a pacemaker, which included symptomatic patient with low cardiac output, asymptomatic adults with congenital complete heart block, infant with normal anatomy and ventricular rate less than 55 beats per minute, infant with other structural congenital heart diseases and ventricular rate less than 70 beats per minute, children beyond the first year of life with an average heart rate less than 50 beats per minute. So should we have to wait and see? Yes, we should have to wait and see for the patient cardiac condition, contractility, and tissue perfusion. So we are not in hurry to insert a pacemaker, whether it's permanent or temporary, as long as the patient is maintaining his vitals, maintaining his tissue perfusion, maintaining his serum lactate, and the important thing is gaining weight adequately. As we know, this was the first home message we always highlight. Infant of systemic lupus mother is always at risk, as we all know, complete heart block, risk of premature delivery, IGR, thrombocytopenia, and the most two important complications that we had to highlight today, hepatobiliary diseases with skin rash. Recently, we have a rush of about 4 to 5 patients with direct hyperbilirubinemia in our NICU. I think during the last 2 months, superficial investigation, which included pelvic-abdominal ultrasound and so on, didn't exclude anything. One of them had direct hyperbilirubinemia. So the mother was investigated for systemic lupus and was diagnosed as systemic lupus mother, and this solved it was a clue for the direct hyperbilirubinemia the patient had. This patient, after 3 months, developed the skin rash of systemic lupus infant or neonate, and this was the clue to diagnose the direct hyperbilirubinemia the patient had. So our two-home message: if the patient is maintaining his cardiac functions, maintaining the tissue perfusion, gaining weight adequately, do not rush for insertion of a temporary or persistent pacemaker, as long as the patient is maintaining his vitals. The second one, do not miss the diagnosis of infant of systemic lupus mother in the patient with direct hyperbilirubinemia or elevated liver function. Thank you.
شكرا دكتور محمد. الحقيقة we got lucky in this case لأن هو his own pacing كان above 55. أنا شفت حالة كان في جريت أورموند ستريت هوسبيتال، كان بيبي infant of lupus وولدوه بري تيرم كمان وكومبليت هارت بلوك، واضطرينا نحط له external pacemaker. ده لعنة ليه؟ لازم تعرف ممكن يحصل failure to capture الالكتريستي. لازم تبقى عارف هل هو في 3 انواع للاكسترنال بيس ميكر، ولازم يبقى في واحد ستاند باي لو واحد الثريشولد اتغير اللي قاعد جنبه يعني يبقى صاحي 24 ساعه.
ده كان مركب فعلا اكسترنال بيس ميكر ثرو الامبليكال فين بتاعه، هو فعلا ده بالظبط اللي كان بالنسبه لنا، ده التشالنج اللي كان بالنسبه لنا اثناء المانجمنت بتاع الحاله ديت. فكره ان هو الالكتريكال امبلسز اللي باينه على الاي سي جي بتبقى بالنسبه لنا مش هي الحكم الاساسي على البيشنت، لازم يبقى في كلوز مونيتورنج للبيشنت نفسه، مش بس البيسنج اللي باين عندنا على المونيتور.
بالظبط.